Hello, I'm Nathan Smith, and here we report a case of Cutibacterium acnes bioprosthetic aortic valve endocarditis. Cutibacterium acnes is a gram-positive coccobacillus that is typically associated with acne vulgaris and is commonly known as a commensal skin flora. However, literature indicates that this bacteria is occasionally associated with infection of implantable devices, including heart valves. Here we present such a case in a gentleman recently admitted to our internal medicine service. The gentleman was a 78-year-old male with a history of bioprosthetic aortic valve replacement in 2017, who presented to his primary care doctor initially for 5 days of sweats, chills, and atraumatic left calf pain. The outpatient doctor started a workup for this, including ultrasound imaging of the lower leg, as well as blood cultures. Ultrasound imaging at that time showed a left popliteal artery thrombosis, while the cultures grew Cutibacterium acnes. He was started empirically on an oral course of doxycycline, as it was unclear at that time whether or not this blood culture represented a contamination of the blood sample or was a true bacteremia. He was also started on therapeutic anticoagulation at that time. 6 weeks after his initial visit to his primary care doctor, he presented to the emergency department with nausea, vomiting, abdominal pain, and continued sweats and chills. He was afebrile on his presentation to the emergency department and otherwise hemodynamically stable. His physical exam was significant for a prominent S2 without any new heart murmurs or signs of embolic phenomena, including splinter hemorrhages, Osler nodes, etc. As the patient was presenting with abdominal pain, a CT angiogram was obtained and is seen in Figure 3, and it demonstrated a right renal infarct as well as an SMA occlusion. Imaging of the head was also obtained due to recent falls, and it was found that the patient had bihemispheric cerebral and cerebellar infarctions noted. Blood cultures were taken on his admission, and the patient subsequently underwent transthoracic echocardiogram. This showed a thickened aortic valve but was unable to rule out vegetation at that time. Blood cultures remained negative for several days, and a workup was initiated for hypercoagulability. Of note, a anti-cardiolipin antibody returned positive, and we initially believed that his presentation may be due to antiphospholipid antibody syndrome. However, we continue to pursue the endocarditis diagnosis due to his history. On day 4 of admission, we got a transesophageal echocardiogram, which did demonstrate vegetation on the aortic valve. We started cultures for culture-negative endocarditis, but the subsequent day, the initial blood cultures returned positive for gram-positive rods, and a couple of days later speciated to Cutibacterium acnes. The patient was initiated on vancomycin with a planned 6-week course from negative cultures. So infective endocarditis secondary to Cutibacterium acnes remains a rare entity, but as in this case, presented without classic signs such as fever or new heart murmurs, and may have prolonged periods of negative cultures that make it a difficult diagnosis to obtain. The fact that this bacterium also is a commensal skin flora makes it really easy to dismiss as a possible contaminant, and again makes it difficult for us to interpret data that we have. One such study that evaluated Cutibacterium acnes endocarditis found that approximately 80% of patients with this infection required surgical intervention to remove the infected valve. As such, awareness of the risk in patients with prosthetic valves should inform our decision to begin empiric antibiotics and consider more indolent bacterial sources of infectious endocarditis in patients with atypical presentations, such as our gentleman.